Good afternoon. On behalf of the National Academy's Forum on Mental Health and Substance Use Disorders, I'd like to extend a very warm welcome to all viewers of this webinar on Strategies and Interventions to Reduce Suicide Part 1, with a focus on U.S. suicide subgroup trends and opportunities in healthcare to reduce risk. My name is Matt Tierney, and I'm a nurse practitioner with clinical and faculty duties at the University of California, San Francisco. I represent the American Psychiatric Nurses Association on this forum, and I'm so pleased to serve as Workshop Planning Committee co-chair on today's exciting offering. More information about the background of the forum can be found on the web page shown on this slide. This is the fourth workshop on the forum from the Forum on Mental Health and Substance Use Disorders, with previous workshops including an October 2019 workshop on key policy challenges and opportunities to improve care for people with mental health and substance use disorders, a summer 2020 three-day virtual workshop on caring for people with mental health and substance use disorders in primary care settings, and a November-December 2020 workshop on mental health and substance use disorders in the era of COVID-19, with a special focus on the impact of the pandemic on communities of color. Published proceedings are now available online for the first two workshops. Late in 2020, members of the forum made the decision to focus the current workshop on strategies and interventions to reduce suicide, and we're so pleased to have experts from around the country presenting today. Today's webinar is part one of a two-part workshop, with part two to take place remotely on July 28th, starting at 11 a.m. Eastern Time. Today's first part will examine the scope of the public health problem of suicide, discuss the implementation of effective approaches for suicide prevention, and address the known barriers to healthcare access. The second component on July 28th will discuss crisis systems, highlighting the 988 expansion initiative. Through a health equity lens, both parts of the workshop will also explore the gaps, challenges, and needs for marginalized populations. A summary of this workshop will be published by the National Academies of the National Academies Press. Thank you to the presenters, the planning committee members, the staff and officers of the National Academies, the forum members, and to you for being here today. I'd now like to introduce my planning committee co-chair, Dr. Mary Rory, who is the Behavioral Health Equity Director in the Office of the Assistant Secretary for Mental Health and Substance Use. Dr. Rory.
Thank you, Matt. I want to echo our fearless leader and chair, Matt Tierney's sentiments. He's said everything that I was supposed to say, but let's see if I can put a different spin on it. Special thanks to all of you for making the time to be here today, to our distinguished panel members, to Allie and Anicia, because without them, there would have not been a meeting. Mega thanks to our fierce chair, Matt, and we cannot thank enough for overly driven, so much fun to be around, dedicated fellow planning committee members. This is a great exemplar of how government, private industry, and academia can successfully work together to increase the awareness and give a call to action. Thank you, and thank you some more. Now, what I was asked to do. We're giving a 2-for-1 special here today. And as Matt has already mentioned, we strongly encourage you to also attend the second webinar, which will be on July 28th. Again, the second webinar will be building on 988, an opportunity to build inclusive care structures and the challenges. And then a recording of this webinar, along with the slides and meeting materials, will be archived on our event webpage shown on this slide. We also encourage you all to use the Q&A button at the bottom of the screens to submit your questions for speakers, and that the questions will be answered during the Q&A portion following each session. Now, before I pass the baton on to Dr. Jane Pearson, one of our fierce committee members, I want to say our call to action for all of you is to leave this workshop on fire for ensuring zero suicide. Moreover, to prevent suicide and suicide disparities of any kind across the lifespan. What we will hear today from our distinguished panels is the scope of the public health problem, the implementation of effective approaches for suicide prevention care, and how to address the known barriers to healthcare access. So the good, the bad, the not so good, and ugly of suicide. But again, a call to action to have zero suicide moving forward. I will leave you with this quote. It's my quote, I believe, at least I claim it. If we do all of this, then together we'll get there together. Thank you so much. Dr. Jane Pearson, you're up.
Thanks, Mary. Hi, I'm Jane Pearson from the National Institute of Mental Health, and I'm the moderator for the next two parts of this meeting. We're going to begin this session with two experts who will provide 10-minute presentations that'll provide the context for the workshop today. And then after that, we're going to have two additional speakers joining those experts for a panel discussion, and we'll be taking some of your questions, and I'll explain a little bit about that later. Our first speaker is Dr. Jeff Bridge from Nationwide Children's Hospital, and he'll provide an overview of suicide rates and trends across the life course and include racial, ethnic, gender subgroups. And our second speaker will be Dr. Crystal Barksdale, my colleague at NIMH, and she'll provide an overview of mental health service use trends by subgroups and consider some of the barriers to healthcare as well as opportunities to reduce disparities. So let's get started. I'll turn it over to Dr. Bridge and his presentation. His first slide is up, I see. So take it away.
All right. Thank you, Dr. Pearson. I am delighted to be here. I first want to just thank the Planning Committee for inviting me, and to Dr. Pearson for generously sharing her slides. I've done my best to keep them intact, so thank you for that. Next slide, please. So just a few disclosures. I received research grant funding from NIMH, the CDC, and PCORI, and I'm also a member of the Scientific Advisory Board of Clarigent Health. Next slide. In my 10 minutes, what I'm going to attempt to do is to talk about the national trends in suicide and suicidal behavior. Then I want to focus on some important population subgroups, and then discuss suicide in the era of COVID-19 and the Black Lives Matter movement, and structural and systemic racism, and then some opportunities and challenges. Next slide, please. Okay, so what this slide is showing is suicide is the 10th leading cause of death in the United States. And as you can see, heart disease, cancer, they have rates upwards of 10 times higher. But being the 10th leading cause of death in our country means that in 2019, there were 47,500 deaths that occurred. And this is across the lifespan among young people, ages 10 to really 34. Suicide is the second leading cause of death. So we're going to delve a little bit deeper into that. And one of the things that I'm going to do is my slides typically will show age-adjusted rates for the whole population, and then I break it down into young people. Next slide, please. Okay, so what this slide is showing, it's suicide rates, age-adjusted, so this is everyone in the US from 1999 through 2019. And what you can see is that across the board in males and females and overall, suicide rates have increased. They increased 33% overall. And one thing that should be apparent is that the suicide rates in males across the lifespan are higher, about 3 to 4 times higher than in females. And this is true across the lifespan, but there is a gender paradox, a sex paradox in suicide and suicidal behavior, in that females, and in particular young females, tend to attempt suicide at 3 to 4 times the rate of young males. But there's the flip in terms of death by suicide. Next slide, please. Okay, so orienting you to this slide, this is now showing suicide rates among 10 to 19-year-olds in the US. And I'm sorry, I'm going to have to ask you to push the button once. Okay, so if we look at our low point of around 2007, Would you hit the button one more time? Advance. There had been an 18% decrease in the suicide rate from 1999 through 2007. Advance, please. But an 88% increase in the suicide rate from 2007 through 2018. And if we looked at 2019 data, the rates went down a little bit, but they would still be about an 80% increase. Next slide. If you would hit the button 4 times, please. Thank you. Whoops. Thank you. So what we see here is similar trends for males and for females. There had been that decline in both boys and girls during that period. Then you get up to 2007, and there was a 75% increase in males and 147% increase in young females. And what that contributed to was a narrowing in the gender gap in suicide among males and females in this age range. Next slide, please. Oh boy. Next slide. I'm sorry, that didn't turn out so well. Okay, let me orient you to this slide. What this is showing is suicide rates in the US from 2000 to 2019. And what I did is I just broke the data into 2 10-year periods. And what you can see here is that suicide rates among white individuals across the lifespan are higher than every other population racial subgroup in the US. And while the rates went up in the period from 2010 to 2019, you can see that this pattern persists. Next slide, please. But if we look at children and adolescents, there's a very different pattern here. Suicide rates among American Indian, Alaskan Native youth in the US are significantly higher than in every other racial subgroup in the country. Next slide. And what I wanted to do here is, so now if we look at 10 to 19-year-olds and we look at by sex. So I had made a statement earlier about generally there is that males have higher suicide rates than females in the US. That's not true for young people. Advance 1, please. 2. Thank you. So suicide rates are roughly 35% higher in American Indian, Alaskan Native females compared to both Black and Asian Pacific Islander males in this age group. Next slide. When we look at ethnicity in the US, this is by all ages, non-Hispanic individuals tend to have higher suicide rates. This is true for both males and females. And advance the next slide, please. And among 10 to 19-year-olds as well. Although, if you look at the difference in rates among young females, there is definitely a narrow gap there. And so that is of interest to us in suicide prevention. Next slide, please. Okay, so let me orient you to this slide. So I put this slide on here to talk a little bit about geography in suicide and urban-rural differences. And let me orient you to the slide. So states in dark blue have the highest suicide rates in the country. Each shade lighter is a lower risk of suicide. So when you get to that sort of light pale gray, whitish color, those states have the lowest suicide rates in the country. If I were to take, I was going to do this, but in the interest of time, I didn't. I could take 20 years of the same picture using annualized data. And there would be some variation, but there really would not be much variation in terms of states with the highest suicide rate. Now, what might explain some of that? Some people have thought about access to guns, Mountain West, Alaska, higher density of firearms. Others have talked about access to healthcare with less population density. That means that people typically have to travel further to access their healthcare. In my mind, I haven't seen a study done, and it would be a really good study to do, is if we could really begin to understand the contributors to this geographic variation in suicide in the US. Next slide, please. Okay, so now I want to switch and talk about suicide in Black youth. Next slide. Thank you. So let me orient you to this slide and I'll just give a little background to this. So my team, beginning in about 2015, we had done a paper looking at trends in suicide among 5 to 11-year-olds in the US. And what we found is that when we looked overall at the data, there was no difference, no trend to speak of overall. It was only when we stratified data in terms of race did we see two divergent patterns. The divergent patterns were among white children, and in particular, white 5 to 11-year-old boys. There was a significant decrease in the suicide rate during this period of time. It was a 20-year period. When we looked at Black children, the opposite pattern occurred. There was a significant increase over time. And there was an open question to this paper, which was, okay, we decided to look at 5 to 11-year-olds because we were defining, we had an interest in elementary school age children, but we didn't know what the higher end would be for this potential age-related disparity. So we did this paper to examine that. And what we found is that suicide rates among Black preteens in the US are higher through age 12. And this is true overall for boys and for girls. And then those rates begin to decrease relative to rates among white youth in the US throughout the rest of adolescence. Next slide, please. Next, advance one. What this slide is showing is if we look at leading causes of death among Black youth and white youth among 5 to 11-year-olds in the country, in 1999, suicide was the 16th leading cause of death among Black youth. And it was the 12th among white youth. And then over time, what you can see is that in 2009, for both Black and white youth, it was the 11th leading cause of death. And now in 2018, it is the 7th leading cause of death. Next slide. This slide doesn't look, okay. So what this slide is showing, actually advance the slide by one, please. Okay, so if you're looking at non-fatal suicidal behavior over time, trends in non-fatal suicidal behavior, Michael Lindsay and his colleagues published a paper a couple years ago, really nice paper using youth risk behavior survey data. And what they found is that generally, if you looked across racial ethnic groups, there was a decline in suicidal thoughts and behavior among all these groups. But if you looked at at Black adolescents, there was a significant linear trend increase in the suicide attempt rate for both Black boys and Black girls. And in particular, there was an increase for Black males in suicide attempts requiring medical treatment. So these are more serious injuries, which is very concerning. Next slide, please. Okay, so briefly about suicide in preteens. Okay, so this slide shows suicide rates by age from age 1 to 19. Advance one, please. And what you see here is that suicide rates, actually the CDC doesn't even calculate, they don't estimate suicide in children under the age of 5. But what this slide shows is that in both males and females, the rates are very low prior to age 10, but then they begin to accelerate through adolescence. Next slide. Advance one, please. Advance two. Okay, what this slide shows is when we're looking at suicide deaths among 5 to 12-year-olds. So if we expand that 5 to 11-year-old elementary school age frame into preteens, we see a 280% increase from the low point in 2008 to 2018. Next slide. Advance one, please. I'll just explain this very quickly. So what this slide is this was a paper done by Mishara and his colleagues in Canada. They looked at suicide rates in the US among 5 to 11-year-olds, 12 to 15-year-olds, and 16 to 18-year-olds. In all groups, there was a significant annual percentage change in the suicide rate. I highlight the 5 to 11-year-olds because it was the highest 14.7% annual percentage increase in the suicide rate during the period from 2012 to 2017. Next slide, please. This again shows a trajectory that we don't want to see, which is as a leading cause of death among 5 to 12-year-olds. It is approaching that of 13 to 17-year-olds. Next slide. Okay, for non-fatal self-harm presentations to the emergency department among preteens, advance 1, advance 2, a 454% increase in the self-harm rate. And I can say, we can talk about this during the panel discussion, but the effects of COVID on our system, on others. In Colorado, the Colorado Children's has declared a state of emergency because so many young people are presenting to the emergency department with suicidal thoughts or behavior. Next slide, please. If we talk about sexual identity and suicidal behavior, next slide. One of the things that has happened recently with National Violent Death Reporting System is that they now capture information about sexual identity, sexual orientation. It's a variable that is now in their database, but it hadn't been before, which made it very difficult to understand at a regional or a national level some of the factors associated with suicide by sexual orientation or sexual identity status. And so now we're going to be able to do that. We still have to wait for more data to come in, but it's a really positive direction. Well, what I want to show here is that for youth, this is Youth Risk Behavior Survey data. For students who identify as lesbian, gay, or bisexual, they have the highest rates of thinking about suicide, planning, attempting, than heterosexual individuals. Those who identify as not sure, who may be questioning their sexual identity, their rates are intermediate between the two groups. Next slide. And then this pattern is just same for when we're looking at for youth who identify as having a same-sex partner or an opposite sex partner only. And you see that those that identify as only having same-sex partners, they have higher rates of suicidal thoughts and behavior. Next slide. COVID and suicidal behavior. Okay, next slide. So this is the study that was done by Paul Neistat and his colleagues in Maryland. What this slide shows is, so it's showing a timeline of 2020 on the top and a percentage change. And then it's looking at 2020, the numbers of deaths that occurred. Now, these numbers get really small, and so you have to take them with a grain of salt. The take-home message here is the divergent pattern between white and Black individuals. So among Black individuals, there was a 94% increase during this period compared to white individuals, where there was a 45% decrease. Next slide, please. Advance 1, and I'll just explain this in the interest of time. Okay, thank you. This is looking at suicidal ideation, anxiety symptoms, substance use, trauma, stressor-related symptoms during June of last year. And the take-home message here is that for younger adults, for racial and ethnic minorities, for essential workers and unpaid adult caregivers, there was a disproportionate they experienced disproportionate mental health outcomes compared to others. And so this is all pointing in the direction. Right now, we don't have final mortality data available to examine the impact of COVID on suicide. We don't have that yet. That will probably happen at the end of December, would be my guess. So nobody can really look at that using national data. Next slide, please. Okay, so at the same time, I mean, COVID wasn't happening in a vacuum. And I wanted to, so I did a search of COVID-19 and suicide, just those two terms, and I found 720 some articles. I did a search of suicide and racism. I found a few articles. I did suicide and structural racism, not many. I did find this one, which is really a promising study. So would you advance one, please, Anicia? Thank you. So the take-home message of this study is, for several of us on this panel, we've been on other panels that has looked at how do we address the problem of suicide among Black youth. And one of the big issues that comes up is that we need culturally sensitive adaptations of effective interventions to help. And Dr. Lavome Robinson and her colleagues at DePaul, they have begun the process adapting Greg Clark's Coping with Stress course through a cultural sensitive lens. And the take-home message here is that the results look promising. The adolescents were very favorable and receptive to this intervention. Next slide. Do I have time, or should I just, am I good? No time. Okay, thank you. I'll talk more at the break. Sorry, thanks. Bye.
Thank you. It's a lot to cover, and we kind of gave you almost an impossible task. Thanks for the great overview. Okay, let's move on to my colleague, Dr. Barksdale, and maybe she can make up a little time on this because we'll have more time in the discussion, but put up a challenge for you, Crystal. Go ahead.
Yes, sure. Thank you, Dr. Pearson. Thank you. Next slide. I will try to scoot through this pretty quickly. So I'm going to just briefly talk about suicide prevention and mental health services and give a little bit of a summary of mental health service use among subpopulations, many of which you've heard about in terms of some of the epidemiology of suicide rates and suicidal behaviors, and then talk about opportunities and next steps. Next slide. So just very quickly about NIMH, we are the lead federal agency for research on mental health disorders and mental disorders. Our institute supports more than 3,000 research grants and contracts at universities and other institutions across the country and overseas. And in addition, NIMH intramural research program supports approximately 600 scientists working on the NIH campus. And this is our vision and mission. Next slide. Next slide. So a little bit about suicide prevention and mental health services. We know that services addressing suicide prevention can occur in various settings, including crisis centers, health centers, clinics, in the home, and other locations specific to the population. For example, older adults may use services in rehabilitation centers or nursing homes, and children and adolescents may be primarily served in schools, and I'll talk about that in a moment. Indeed, suicide prevention requires active engagement of multiple systems, and this becomes critical. And the coordination of care across multiple settings, which ensures a continuity of care. The integration of suicide prevention into the delivery of mental health services has been found to help prevent suicides. And this fosters a comprehensive approach to care by encouraging increased collaboration between and coordination of services among providers. Individuals at risk for suicide often, though, do not seek help from mental health services. And this is especially true for youth and minoritized populations for a variety of reasons, which I will discuss momentarily. This is particularly important because it exacerbates disparities. So in promoting effective suicide prevention, beyond emphasizing the use of mental health care services as a component for prevention efforts, it's important that we understand help-seeking behaviors. And so a critical component of that in understanding help-seeking are understanding some of the questions. What are the usual sources of help when people are in need? What are the beliefs about seeking help from mental health services? What have been some of the past experiences? So I have here an article that has really been, I think, poignant in highlighting some of those concerns, but also in some of those considerations, specifically around help seeking for mental health services and suicide prevention. Overall, we want to provide and make available, as Dr. Bridge just pointed out, culturally and linguistically appropriate mental health care services that meet the needs of individuals at risk, and then encourage individuals to see these services as an option to address their needs. Next slide. So I want to talk now, next slide, about some of the mental health service use in specific subpopulations. And I'll start with mental health services across racially and ethnically diverse groups. So what do we know from some of the research? Well, intersectionally across different age groups and racial and ethnic groups, mental health service use is low. On average, about utilization tends to be below 50% among youth and adults across racially and ethnically diverse groups compared to white individuals. Racially and ethnically diverse individuals are less likely than white individuals to receive follow-up care from mental health service providers. In addition, context and settings are critical for youth populations. Racially and ethnically diverse youth are much more likely to access mental health care services in school contexts compared with community contexts or community clinics. And there are fewer disparities in service use for youth in schools compared with community clinics. This is especially noteworthy when we think about the additional impacts of the COVID pandemic on minoritized communities, and particularly youth minoritized communities, and the exacerbation of disparities, since racial and ethnically diverse youth who are more likely or maybe more likely to access mental health care in schools are not or haven't been attending school in person, thus they're not accessing their usual source of settings of mental health care. Next slide. So some of the reasons why racially and ethnically diverse groups may not be or are underutilizing mental health services vary, but again, some of the top or most cited reasons include stigma surrounding seeking help, structural inequalities in the mental health care service system, limited knowledge of and access to resources, also the limited availability, again, of culturally and linguistically competent or culturally appropriate services, and again, the limited mental health care literacy or limited mental health literacy. Next slide. So with regard to mental health service use among individuals living in rural areas, in 2014, analysis of the National Violent Death Reporting System data revealed that rural decedents were less likely than urban decedents to have a mental health diagnosis or mental health care, although the prevalence of depressed moods appeared similar. So again, with regards to reasons why mental health care utilization might be lower among rural individuals, some of the reasons are as follows. Again, stigma is a commonly known reason, a commonly cited reason. It's also well documented that individuals living in rural areas suffer from shortages of mental health care professionals, particularly pediatric mental health care specialists. Of all non-metropolitan US counties, for example, it's cited that 65% are without psychiatrists, 47% are without psychologists, and 27% without social workers. It's also known that individuals living in rural areas have lengthier travel distances to providers. So not only are there mental health shortages, but again, there's also a lengthier travel distance or longer distances to reach. And they also experience other access challenges. Cultural factors may also play a significant role in help-seeking behaviors among rural individuals. And even when services are available, rural residents may not see the need for services, also because of low mental health literacy. Finally, the lack of anonymity and concerns about confidentiality is also cited as a common reason for why there's underutilization of mental health care services among individuals living in rural environments. Lastly, even when individuals living in rural areas do seek care, they do so later, often with more serious symptoms and require more expensive or intensive treatments than do their urban counterparts. Next slide. Mental health service use among sexual and gender minorities, though the research findings are mixed with regards to individuals who are sexual and gender minorities, patterns suggest that overall sexual and gender minorities are less likely to seek mental health services. I will just note that some of the research is mixed, often because sexual and gender identity is not accounted for in some of the literature, and that is a significant factor. Transgender individuals have been found to have significantly different experiences in accessing mental health care, specifically in terms of being denied care and experiencing discrimination based on gender identity and expression. And when that is not taken into account, or when gender identity is not included, or subgroups are not included into the research, that is sometimes obscured. Despite some of the mixed findings, sexual and gender minorities in general, again, are less likely to remain in treatment compared with heterosexuals. And the research among sexual and gender minority youth is clearer and more equivocal, suggesting that youth are less likely than non-sexual gender minority youth to seek help. Again, with regards to some of the reasons for underutilization, lack of family support and support to seek services. Again, there's a general consensus likely due to stigma. There's also issues with regards to concerns about privacy and disclosure, and the lack of availability of LGBTQIA plus affirming services and the availability of, again, culturally appropriate services. Next slide. So with regards to opportunities and next steps, I offer this model. The CDC provides a valuable guidance based on the assumption that prevention efforts for any health or disease issue require integrated multi-level efforts within a social ecological model. And this is the social ecological model for suicide prevention. This is a 4-tier framework for organizing risk and protective factors, which then can inform corresponding prevention strategies. And so from the macro to micro levels, the 4 strata are seen here. I'm not going to go into it in much detail. I can talk about it during the discussion, but I offer this and provide this because I think it's a valuable model, providing a great framework for organizing our understanding of risk and protection, illustrating how one level might influence other levels, and also provides a great framework and grounding for multi-level interventions and prevention programs that I think are critical to how we might address this really complex issue of suicide and suicide prevention. Next slide. And then in terms of other opportunities and next steps, I think some of what Dr. Bridge was pointing to in his talk, there are certainly opportunities for us to improve our data collection. There are several gaps in epidemiological data and ways that we need to improve our ability to collect data on not only in general, but certainly on data on minoritized youth and intersectional populations. I also think it's imperative that we think about ways to identify individuals, especially minoritized youth, who are at risk for completing suicide and dying by suicide. And then finally, there's more information. Go back. Thank you. There's more information and research needed on the best approaches to prevent suicide, especially among minoritized youth, and ensuring that these approaches are not only developmentally appropriate, but also culturally relevant. Thank you. Next slide. And then finally, at NIMH, we have a number of opportunities available to help encourage this research, some of those research opportunities. And so if you're interested, some of them are listed here, but you can also sign up for the guide at that link available. And that's it. Thank you.
Great. Thank you, Dr. Barksdale. So stay on and let's get Dr. Bridge back on the video. And then we're going to ask Dr. Holly Wilcox and Dr. Richard McKeon to join us. And we're kind of getting squeezed into a limited time frame here for questions. So I'm going to ask Dr. Wilcox first to give your reactions in terms of some areas you think were touched upon. We also know you do a lot of work in the schools. I don't know where you would like to start with a few comments just for a couple minutes, then we'll ask Dr. McKeon and we'll open it up for questions.
Sure, thank you. And thank you for those great presentations. There's a pressing need to have layered stacked suicide prevention approaches, like, for example, policies and protocols for workflow, training, developmentally timed, layered evidence-based practices, coordination across systems of care, better use of data for action. And as Dr. Barksdale pointed out, there are just a lot of barriers to engaging youth and adults in our traditional array of mental health services for many reasons that she pointed out. And we lose people along each link in the chain of care. There's some promise, I think, to be able to better leverage technology to overcome some of these barriers, but there is a very pressing need to focus more effort and attention upstream. As well as to those who are already in crisis, we also need to be thinking upstream and how to prevent crises from happening. And I'll stop there.
Great, thanks. Dr. McKeon from SAMHSA, some of your comments.
Here we go. Thank you to the presenters for what they went over. I wanted to make 2 points. One of them would be having to do with the Garrett Lee Smith grant program. And you notice those trends in youth suicide prevention. And I'll mention just a couple of things. But by statute, the Garrett Lee Smith grants are age 10 to 24. So unfortunately, they don't reach down to the age group below the age of 10. That's particularly unfortunate because we have evidence that there is a long-term impact on youth suicide mortality from these grants. And the slide that you're seeing in front of you shows that the impact in reducing suicide, in youth suicide specifically, in counties implementing Garrett Lee Smith grant-funded activities is lower than in matched counties who were not. And what this slide shows is that that impact was directly related to years of continued activity. Another way of looking at it, years of continued funding. So counties that were doing this work for 4 years consecutively rather than 3 had a deeper and longer impact, 3 than 2, 2 than 1, et cetera. So this says a lot about sustainability, I think, and the need for suicide prevention among youth, but I think you can generalize this to other populations, to be a continued focus. It can't be a one and done. Interestingly, the impact of our Garrett Lee Smith grants was greater in rural counties than in other counties. Rural, but not frontier counties. So that was one point that I wanted to make that I think was important. The second was that, there was some important data which mirrors some that SAMHSA has regarding people at risk for suicide with suicidal ideation who have even made suicide attempts, not getting mental health care. And we have found very similar results in terms of people feeling either they don't need help, or perhaps it is that they don't want the kind of help that they perceive the mental health system as offering. And I think that that's an important point because we have to be aware that there are many people at risk who are just not getting into our care systems, and we need to be able to pay better attention to them. So those are the 2 major points I wanted to make. Thank you, Jane.
Thank you. One of the questions.
And that data just shows you the greater impact in rural areas.
Great, thank you. One question that came up that I think I answered already was, what do we know about the 2020 rates? And Dr. Bridge, I'm wondering if you could say something about surveillance and the timing of when we get data and what we can do with it.
Sure. So typically we get national mortality data about a year after the year happens. So we should be getting data for 2020 in around December of this year. What the CDC has done recently is that they have developed a system that's their Vital Statistics Rapid Release System. And what it does is it provides provisional mortality estimates quarterly. And so while it's not a final determination of death, it does allow for more rapid looks and surveillance of the issues.
Great. One of the questions was about the role of religious culture. And I'm wondering, Dr. Barksdale, if you want to say something about settings that some subgroups feel a bit more comfortable. And it could be that some subgroups feel very uncomfortable in certain religious settings. So if you want to say a little bit more about different setting contexts and that.
Yeah, thank you for that question. I think certainly there have been several studies that have involved and included religion and religious settings as a source of care and have shown that individuals prefer to seek help from their religious provider or their religious their source of religion and done so quite well, and that's their primary source. And then others again have seen that as a source of stigma. So again, I think it kind of depends on the kind of cultural cultural relevance of the help seeking source. But I think it's an important point that we understand help seeking preferences. And there's a lot of work kind of understanding that as a preference, and a lot of work in terms of engaging religious entities and religious institutions in mental health in general and in suicide in particular, as suicide as a suicide prevention source, to help us understand how to prevent suicide. So I think certainly it's worthwhile, but it's also understanding how to address the stigma that might be associated with it, because there's still quite a bit of stigma. As you saw in the slides, stigma comes up for each population, each subpopulation. So
thank you. That's good. So Dr. Wilcox mentioned schools, and we were talking about different settings. And I think you also mentioned that we could probably reach more kids in schools just because of the health access piece. That just brings up multiple settings where you could find people, the transitions. I know Dr. Bridge has done some work in that area. Dr. Wilcox, why don't you go first, Dr. Bridge?
Sure, just to highlight schools again, I mean, completely in favor of that upstream approach. If we can reach youth early, if we can reach individuals well in advance of a small issue becoming a big problem, we will take tremendous strides in reducing suicidal behavior. As far as care transitions go, absolutely critical. We know there are high-risk transition periods. They occur in emergency departments. Primary care is a perfect setting to screen for suicide risk and triage and do the appropriate risk assessments. But what it requires is it does require a system of care. And so the framework that I know we've been talking about as far as zero suicide and others really does have the system in place that when individuals understand a process of care, it eliminates the questions, it eliminates the fear of, well, what am I supposed to do if the child says yes, that they're thinking of having thoughts for suicide? If they know that there's a pathway present, it just facilitates the whole process when everyone knows their parts and roles and how they can help to reduce risk.
Great. There's, I think, a question that Dr. McKeon can address. Somebody was asking about 911, and I'm guessing that might be 911 calls. And what do we know about the reasons for 911, especially through COVID? Any patterns there that you might want to mention?
Yeah, well, I think that there are a couple of issues. And these are important. I know we'll be talking more about 988 in the second session. there, because 988 will be an alternative in many instances to 911. And I think that the issue that gets to is whether suicidal thoughts should always be considered an immediate emergency, and whether the response to such an emergency would be to use whatever means possible to get somebody to the emergency room. And I think there's reason to think that that is not the most effective system. And one of the things that we saw, I think, during the pandemic is that, and particularly in the early couple of months when emergency room visits dropped, many localities, for example, in New York City, were doing absolutely everything they could to bring someone to any place but the emergency room. And many people were themselves wanting to avoid the emergency room because their fear that it could be a place where they could be exposed to COVID. So there are many very important issues, I think, around this. And to the extent to which we can make emergency rooms less central as part of a comprehensive suicide prevention response, I think there are many significant advantages to that, simultaneous with trying to improve care in the emergency room, and very importantly, improve follow-up afterwards. 2 studies from California showed people who made suicide attempts seen in an emergency room over the next 12 months had a 56 times greater rate of death by suicide.
Great, thank you. We actually have to wrap this up and move on to the next session. Thank you all so much. I'll try to answer some of the questions that are still left in the Q&A. I will turn it over to my co-planner, Erin Bagelman. And everybody else can put off their cameras. Thanks.
Thank you, Jane. As Jane said, I am Erin Bagelman. I work for the U.S. Department of Health and Human Services in the Office of the Assistant Secretary for Planning and Evaluation, ASPE. We have 3 great speakers to tell us about experiences in implementing suicide prevention care in federal healthcare settings. Our first 2 speakers, Lisa Brenner and Joseph Simonetti, are from the Department of Veterans Affairs, Rocky Mountain MIREC for suicide prevention. MIREC is the acronym for Mental Illness Research, Education, and Clinical Center. Our third speaker, Pamela Endethorn, is from the Indian Health Service. Now I will hand it over to Lisa Brenner, who will speak to us about the VA DoD clinical practice guidelines.
Erin, thank you so much. I really appreciate being here and having this opportunity to speak this morning, or this afternoon now. Hoping to talk a little bit about clinical practice guidelines. And, not everybody kind of spends a lot of time thinking about what clinical practice guidelines are, what they do, what purpose they serve. And for me, clinical practice guidelines are, they can help guide treatment, but they also really guide where we're at in terms of our current knowledge. And suicide prevention, thanks to NIH and VA and other groups, we have really come a long way in terms of suicide prevention research. And in the last session, you just heard a lot about different studies that are happening. This much work, this much movement, this quickly is new. And really, this area of research is still unfolding in time. So I think what I'm going to end up telling you today is these are some areas that we've made some great gains. And also watching with me, these are areas that we still need more work, we still need more attention, we still need more input. And we especially need input from people about what kinds of services they prefer and where they would see us like to go in the future. So these were put out in 2019, these clinical practice guidelines. And needless to say, there's been research since then. And the previous clinical practice guidelines were several years before that. And I have to say that this has been a huge leap in about the 6 years in between the previous one and this one, huge leap in what we know. Next slide. This is my disclaimer, which I should have said before I even said anything, but this is all me, not the VA today. Next slide. So what we do in these, and you'll see we pick specific questions, and that these specific questions then guide us towards data and research in these specific areas. And we have 22 recommendations that I'll talk to you about today relatively quickly. And something to keep in mind, the recommendations, they range from strong to weak. And often when you think of a weak recommendation, you think maybe that's not so good, there isn't evidence. In this case, weak means good and strong means really good. So kind of have a different hat on when you're thinking about this measurement with me. And then there can be recommendations for something. So this is a good thing to do, or against, this is not a good thing to do. And even though we've made big gains, I think what you'll see is a number of places where we still need more work. Next slide. So this was a multidisciplinary group of experts who came together. We came up with the most important questions for the VA and the DoD. And again, the idea is that we're able to identify the best evidence and then take that best evidence and put that into practice. And you'll see that I'm speaking a little bit later. I'll talk a little bit of how we take this evidence and put it into practice. And we come up with questions, so key questions. So for example, for patients identified as being at most risk, what are the most effective treatment approaches? And we're really interested in like for whom, where, and when. This gets us back to a really important point. Most of the research has been done on not minority populations. And I think that, you know, whether or not these findings hold for different groups, and in the past session, we heard about adapting interventions, making things more culturally appropriate. Lots of the work I'm going to present today is made off, is really research that's been done with majority populations. And the question still exists, do these work equally as well for individuals from different backgrounds, different orientations, different histories? So we go through, we get these questions, we get all the evidence, and then we come up with these recommendations, and we have other people make sure that we are kind of doing it right and have a lot of transparency. And so this is what we came up with in the end. Next slide. So there's 5 recommendations about screening and evaluation, 12 recommendations about risk management and treatment, and 5 recommendations about other modalities. Next slides. If you look in the clinical practice guidelines, and if you're at all interested in this, what I would kind of recommend to you is go to the page that looks like this. This is the recommendation table, and you're already becoming experts with me in clinical practice guidelines. You can see these are organized by area. So here's screening and evaluation. You can see it's weak 4 or strong 4. And then this other category at the end is this new information? Is this a new recommendation, or do we have new evidence? Or was this amended, which would be we had this as a recommendation before, but we're just updating based upon what we know now. Next slide. So here's some example recommendations, and I think that these are specifically things that we have in the VA DoD clinical practice guidelines, so in our federal systems, but this was based on evidence, all the available evidence. And so these recommendations really could stand for any system of care. Next slide. So this is one of our strong 4s, and that we recommend an assessment of risk factors as part of comprehensive evaluation. And that should include things like ideation, prior attempts, psychiatric history. And what we did is we went through each of these things and picked out the evidence really shows that these are super important risk factors and they should be included. Next slide. The other great thing and important thing is sometimes, and we hope this is true, that the recommendations that we made line up with requirements from our accrediting bodies. And this case, that did happen, that very similarly to kind of what the recommendations in the CPG are, so what the evidence supports, the Joint Commission is also saying is best practices and should be implemented. Next slide. There's non-pharmacologic interventions. I'm real brief on time today, so I'm not going to go into detail here. So here's the non-pharmacologic. Next slide. Again, more for non-pharmacologic. So these are psychotherapies that are recommended. And some of these are going to be familiar to you, like problem-solving therapy or cognitive behavioral therapy. Next slide. I'm going to have you keep going. One thing that is recommended is crisis response planning or safety planning. There's week 4 evidence for this. We highly recommend that folks do this and engage in this. And this is also an accreditation requirement. So this is great when these things line up. Next slide. Here's some resources that we've also developed along with the CPG. So if you go to the CPG website, it's not just the CPG, there's algorithms, there's other materials there for you. Next slide. Want to highlight that there's pharmacologic treatments, Next slide, that are recommended. And you can see there's definitely some weak evidence for, and more work needed, but weak evidence for. Same with post-acute care. I want to highlight this for a second. Technology-based modalities, this is super important. This is both treatments that could stand on their own, or treatments that are done online, or treatments that are done via video. And that we know that these technology-based modalities really do help increase access. I took this from the NIH and NIMH's webpage that says, some of these apps are free. They can help really reach people in remote areas and rural areas. We've already heard that individuals in rural areas need more resources, and they certainly can access those online. We don't have enough evidence yet for these interventions, so more research needed. Erin, I know 1 more second, I'm going to be done. Next slide. Want to highlight that this has been a super quick run through, but we have a CPG webinar series where we devote entire webinars on each of these recommendations. So really want to highlight that folks go there and take a look. And the next slide is just other ways you can reach us in the MyRec. And thanks, Erin.
Thank you. That was great. Next, Joseph Simonetti will speak to us about opportunities and challenges in promoting lethal means safety among veterans.
Thank you, everybody. I appreciate the opportunity to be here today to talk a little bit about the VA's efforts to promote lethal means safety and some of the work we've been doing. Next slide. Very briefly, I have no conflicts, and same as Dr. Brenner, these are my views and not necessarily the views of the Department of Veteran Affairs. Next slide. Lethal means safety is an intentional voluntary practice to reduce access to lethal methods of suicide in order to reduce suicide risk. This can be accomplished using a cable lock to secure a firearm, or perhaps storing a firearm or the ammunition outside of a home. Or it can include keeping opioid class medications in a secure lockbox away from those in the household who are at risk of suicide. Next slide. Reduced access to lethal methods is one of the evidence-based strategies for reducing suicide rates at the population level. For that reason, promoting lethal means safety through lethal means safety counseling or firearm safety counseling is recommended for individuals with elevated suicide risk by various medical and public health professional societies and guidelines, including the VA DoD clinical practice guidelines that Dr. Brenner just discussed. Next slide. In the US generally, and certainly in the VA, discussing reducing access to firearms is a key focus of lethal means safety counseling. Because in the US, 1/2 of all suicides are attributable to firearm injuries, and among veterans, nearly 70% of suicides are due to firearm injury. Next slide. The Veterans Health Administration has taken a fairly comprehensive approach to promoting lethal means safety through lethal means safety counseling. From a clinical perspective, VA clinicians deliver lethal means safety counseling as part of a safety plan, which is developed for patients with identified suicide risk. And there are now efforts to provide standalone firearm safety counseling for patients with other identified injury risk factors. Our educational mission has rapidly expanded, and we're now supporting clinicians in delivering firearm safety counseling across a wide array of clinical settings and different scenarios. We've also begun developing training resources for individuals in the firearm retail industry to parallel our own counseling efforts, individuals who are key stakeholders in this work, and those are being developed through several of our national partnerships. In the VA's research portfolio, at least with respect to firearm injury prevention, mostly suicide prevention, has similarly expanded in order to keep ensuring that we're delivering high quality and evidence-based interventions to our patients who are at risk. Next slide. I think one of the reasons VA has been able to establish itself as a leader in this field is really the strong foundation from which we're already able to build on. The VA has a pre-existing infrastructure for suicide prevention that is coordinated by national leaders in the field through some level of central coordination, which means that we're rapidly able to disseminate resources to the field and reach a broad number of clinicians and thus a large number of patients through most of our efforts. Next slide. I think the other reason we've been able to move forward with lethal means safety efforts is that, as it turns out, there's generally a really high level of acceptability for having these types of conversations in clinical spaces. At least that's what the literature so far has suggested. For example, the 2019 National Firearms Survey shows that about 80 to 90% of those who live in households with firearms in the US agree that clinicians should initiate firearm safety discussions when someone is at risk of suicide. And along with that, there's already a wide recognition about the elevated suicide risk among veterans, including within the veteran community. When asked about discussing firearm safety with clinicians, one veteran once told me, "It doesn't bother me coming from them because I trust them. It seems to me it's nobody's business but mine. Then again, I also understand we're losing a bunch of guys every day to suicide. So I understand the question beyond my personal feelings." Next slide. All that being said, there are a few important challenges that we're going to continue to face. Lethal means safety counseling is it's not a single intervention. We need to deliver it across many different settings through different messengers with different messages and to a heterogeneous mix of risk populations. It's really critical to avoid monolithic thinking generally, but certainly in this respect about the firearm familiar community, and a challenge for researchers in the field to be develop and disseminate interventions that are effective, feasible, and tailored to these various different audiences and settings. Next slide. Another really important challenge is related to our efforts to move suicide prevention interventions upstream. This is really critical. We all know this because we know that many of our patients who go on to die by suicide are not engaged in specialty mental health treatment, where safety planning and lethal means safety counseling maybe feel more naturally fit. Shifting responsibilities for these tasks to clinical spaces that may be less accustomed to mental health treatment or suicide prevention generally is probably going to require a shift in clinical practice for a lot of people and perhaps even clinical culture. It's one thing, I think, to provide a psychologist with better tools to deliver firearm safety counseling. It might be a whole different challenge to begin thinking about how we facilitate the delivery of these discussions in, for example, medical and surgical subspecialty settings that don't consider suicide prevention to be within their clinical purview or wheelhouse. And it's really unclear if we're going to shift some of these firearm safety discussions to different provider categories and clinical contexts, whether it will ultimately impact the acceptability of these discussions and perhaps even, I think, their effectiveness. Next slide. What's clear from the qualitative and survey literature on the topic is that although there's generally a high level of acceptability, this clinical context really matters. And simply put, patients want to know why they're being asked about their firearms. As one veteran told me, "I think that explaining why you're talking to the person about firearm safety is a good thing, because if you don't, they're going to be like, where is this coming from?" Next slide. I want to finish up today by providing just a little bit of food for thought on recent potential changes in firearm epidemiology and how that might impact our work, at least in the short term, in the VA and probably nationally as well. The past 14 months or so have been marked by quite a bit of, I think, turmoil, uncertainty, and some progress. We've seen political tensions, spikes in firearm violence, a pandemic that's claimed 600,000 American lives and counting, and a broad movement to counter racial injustice nationally. And while there are not sources that we can get reliable estimates of firearm purchasing and safety behaviors from, there's been quite a bit of media reporting and a few sort of small convenient sample studies that I think are informative and I think worth spending a little bit of time thinking about as we move forward. Those sources have suggested that firearm sales have surged, marked by purchases from different demographic groups and those who have different ownership motives, who have a wide range of prior training and experience with respect to firearm safety. And so maybe they also have different firearm safety behaviors. One study even found that individuals who purchased firearms for the first time during the pandemic era were more likely to have suicidal ideation than other firearm owners. As I mentioned previously, part of this work is crafting tailored interventions for a heterogeneous population. And it's unclear whether the past year has spawned these sort of unique risk populations that we know very little about in terms of both their suicide risk and their firearm safety behaviors. Much of our work so far in the qualitative and survey literature has really focused on understanding the perspectives of the firearm familiar community generally. and how that community tends to different perspectives and experiences from those who don't own or experience regularly firearms. And we haven't yet invested in understanding the perspectives of the firearm community based on other important experiences or characteristics such as gender or racial discrimination or trauma victimization. And that puts us at a disadvantage in trying to explain why suicide risk and rates may differ and be on different trajectories among specific populations. And I think it really limits our ability to think about how we should be tailoring our approaches. And this is obviously work we desperately need to pursue if we're truly going to develop and eventually disseminate patient-centered interventions related to firearm safety and lethal means safety generally. Next slide. With that, I'll wrap up, and I look forward to discussing this further today. Thank you.
Thank you, Dr. Simonetti. That was great. So now I will turn you over to Pamela Endofhorn, who will speak to us about the Indian Health Services Suicide Prevention and Care Program.
Good afternoon. I'm Pamela Endofhorn. I am the National Suicide Prevention Consultant for Indian Health Service. Next slide. And I have worked in the field of suicide prevention for about 14 years. I'm a clinical social worker by training. Next slide. Same disclaimer, everything that I'm going to be talking about today is from me. Don't blame my HFs. So next slide. What we're going to talk about today is basically those programmatic elements. We're going to talk about the standards of care for American and Alaska Natives, and we're going to talk about the efforts by Indian Health Service to work with federal, tribal, and local tribal communities in regards to suicide prevention. Next slide. What are we dealing with amongst American and Alaska Natives? I want to thank Dr. Bridges for his great overview of what the scope of the problem is for American and Alaska Natives. We are dealing with a very large issue in regards to Indian country, one that can take over an entire community. Next slide, please. So the Suicide Prevention and Care Program, next slide. The Suicide Prevention and Care Program actually falls within the Office of Clinical Prevention Services under the Division of Behavioral Health. This program is in conjunction with Mental Health, Substance Abuse Administration, and our Telebehavioral Health Center of Excellence. Next slide. And what do? We basically provide programs to tribal communities, tribal nations, focusing on those aspects of care. So everything we do is within the field at local levels, be that a medical facility or a tribal clinic. Now, what you have to understand about Indian Health Service is that unlike the VA is a healthcare system. So too is Indian Health Service. We are a healthcare system, but we are more systems than a system, meaning that we have federal partners, we have tribal partners, and we have local partners. That is a conjunction of the two. So what we do is we work to empower local tribal communities to take what we can provide them in regards to program offerings, funding, information, evidence-based practices, best practice models, and help them implement that at the local level. And so doing so really focuses on that upstream model. We believe that working in the community is helping them raise to the highest level of care that they want in regards to their care, health care, and public health services. Next slide, please. So within suicide prevention and care, we do a lot. Now, I have to understand when I say we, I am speaking primarily about myself and Lieutenant Commander Monique Richards, who is our Zero Suicide lead. So what do? We do a lot of policy work. We work with a lot of our tribal communities and our tribal nations on how do you implement these standards of care. We're doing a lot in regards to screening and, of course, the Zero Suicide Initiative, which I'll talk about in the latter half of this presentation. But in addition to that, we also work with a lot of partnerships. We do a lot of work to help bring this information from the federal to the state and to the local to try to help the tribal communities really build the best program that meets their need as possible. Next slide, please. And so one of these initiatives is the Zero Suicide Initiative. It's one of our best initiatives that have really taught us a lot about suicide prevention within tribal communities and what does it mean to focus on our upstream perspective. Next slide. So of course, the zero suicide model, really looking at the entire healthcare system and implementing 7 elements in regards to suicide care. Next slide, please. What are those elements? Lead, train, identify, engage, treat, transition, and improve. These are all the pieces that our initiative sites have implemented in addition to the cultural overtones in regards to the community in which they exist. And so they've taken these elements, have looked at them through the lens of their cultural perspective and applied it in a way to help them further care and establish treatment protocols for their community. Next slide, please. Our sites are spread, of course, across the United States. And in health service, we provide behavioral health services to 2.2 million American Indians across the US, including Alaska. Most of our zero suicide pilot sites are actually located in the Southwest, 1 being in Phoenix, 3 in the Navajo area, and 1 in the Albuquerque area. But we also have 1 in the Oklahoma City area, Bemidji, and Billings area. So we have a wide swath of pilot sites in which you have to see the differences amongst culture and how they look at zero suicide as a model and how they implement it. Next slide, please. What is it that we've created? Basically, it was a cooperative agreement with our tribes. This gave us the ability and the vehicle to really work closely with the tribes in understanding the model, applying the model, and really understanding what is it they needed to do within their system to help improve care. Now, the project period was supposed to end in October 31st in 2020, but due to COVID, we actually extended them into this year. So they will actually end this year in 2021. What we've understood with COVID, though, is that COVID has brought a real unique challenge to suicide prevention and care within tribal communities, because like other presenters have identified, many of our programs were diverting patients because of suicide, or because of COVID for suicide, simply because of the infection concerns. They did not want people to go to our hospitals or our clinics because we didn't want to infect them. But at the same time, what this has done is spurred this realization in the tribal community is that we can do this within the community. And how do we do this? This has really created a lot of efforts within the school systems because a lot of our kids were home. And it allows the community to really take in consideration, what do we have on the ground? Who do we have? How can we outreach? We had one site in the Great Plains area that established a COVID hotline, so that they actually were putting out on the radio. They had flyers up so that people could call this hotline at the local level. It was like a warm line, crisis line, where they could just talk to somebody if they were feeling overwhelmed by that pandemic, if they were feeling suicidal, and they could then obtain resources, find places to go, others to talk to feel comfortable. And it helped the community really find a cohesive response to the issue of the pandemic and the reality that they were facing in regards to what it was happening and how the infection rates and the number of deaths were occurring within the local level. So COVID really gave a lot of our local sites a different perspective to work from. It was a perspective that we have to maintain this within ourselves because a number of tribal communities actually shut down. They closed their borders. And so in order to stem the tide of infection, they were very much insular. And so this caused them to really start to think about different perspectives in regards to suicide prevention. Next slide, please. And so within our areas, we have 5 tribal sites and we have 3 federal sites. The federal sites have had a really interesting time in regards to COVID and suicide prevention because we had so many of our sites diverting patients and patients not wanting to go to the site. Whereas our tribal sites also had a very interesting aspect in regards to what were they dealing with at the local level and trying to get out into the community, both balancing out providers' fear of infection as well as not wanting to infect people. So it became this push and pull and tug within these tribal sites to really understand what is it that we need to do within COVID, but what is the help that we have been doing in regards to community work, be that doing tribal health fairs, going out working in the schools. A lot of our communities actually love to work in schools and work at the local level to get school children help within the school system. Next slide, please. And so what have we created in regards to our evaluation, looking predominantly at documentation. We want our sites to be able to have quality care that is evident within the documented electronic health record. But we also wanted to look at it from universal screenings and timely follow-up. Next slide, please. And so what is it that we learned? We learned that we need leadership at the local level, that increased training is vital, and that we actually have to have an established quality improvement team on site to help embed these elements and really push forward the model. Next slide. What are our challenges? Oh, so many challenges. First and foremost, without leadership, the model was not going to work. We had to have training, we have to have dedicated staff, and we have to have dedicated follow-up, ensuring case management, and of course, the data. How do we help them obtain data and look at and analyze their data in a meaningful way? Next slide, please. So where are we now? We're looking at crisis lines for follow-up and utilizing care and establishing data agreements. And with that, I'll turn it back to Erin. Thank you.
Thank you so much, Ms. Endifhorn. That was wonderful. And I will turn it over to Ursula Whiteside, CEO of Now Matters Now, who will moderate the next panel.
Thank you very much. I'm going to speak for a few minutes before I hand it over to my colleagues. A little bit about barriers from the perspective of folks with lived experience. I want to start by letting you know where you can find the recommended standard care guidelines for people at risk for suicide as presented by the National Action Alliance for Suicide Prevention. Our last speaker, Dr. Mike Hogan, was integral in making this report happen. I would think of it as a parallel report to the work that Dr. Brenner was doing, but really honing down at minimum, what is it that we should and can be doing in a practical manner with people who are at risk, addressing barriers while using best available evidence as well. Next slide, please. I want to take a moment to look at from the perspective of barriers. So people with lived experience have all sorts of reasons for not reaching out for care or for having poor experiences when they do. And part of that has to do with the explanations that we have around suicide and how it does or it doesn't make sense. Dr. Marsha Linehan developed a treatment called dialectical behavior therapy, and on our team, we use this approach when understanding and explaining where people were coming from. And that was so much to say that essentially there's a history and a biology that informs where people are at on a day-to-day level in terms of their stress. So if you look along the bottom of this image, what you're seeing there is time across the course of a day, for example. If you see up the top of the left, that's a stress level, let's say from 0 to 100. So given a different day, given different individual, given different experiences such as historical trauma, such as systemic injustice, some people are going to run hotter emotionally than other people. They're wired hotter, or their environment is contributing to a higher, we call emotional baseline. And when you run hotter, this is based on Marsha Linehan's biopsychosocial theory of emotion dysregulation. I just call it the stress model when I'm talking about it with people who are struggling. When you tend to run hotter, you make sense. It is caused. And there's a certain set of circumstances that go along with that. So such that when a stressful event happens, your emotions might react more quickly, might go higher and last longer, and maybe not ever get back to where they were or take longer to come back to where they were. Next slide, please. So next. We think about this as being on fire emotionally, and that experience can help explain why people do things that they wouldn't necessarily otherwise do when their emotions get so hot. So I ask you to think about this. We're talking about these evidence-based practices, but how do we think of a person in the context and how they make sense in the way that they got to where that they are at? This image, if you can go back one more, can help family members and friends and clinicians, if you go back one slide, have a better understanding of what that experience is like. So you see this gray area and this green area. Sometimes I talk about it as Mr. Green and Mr. Gray. Or it's the same person within a different period of their life or what's going on nationally around them. So bringing to mind that context. Next slide, lived experience, this personal experience related to suicide, either having had those experiences or loving and caring for someone who has, that's really guiding the work of suicide interventions. And we're getting feedback about the language that we use. So as healthcare providers and others, when we speak, we're not only communicating to others, but we're communicating to ourselves. And so we're working at changing the language that we use when we're talking about suicide. A big one, moving away from the term committed. And also being very thoughtful about the way we describe behavior. There's a lot of judgment around the terms and the assumptions we make about what something means. So very much describing what happened as opposed to adding an interpretation onto that. Next slide. In the work that I do, I have a team of people with lived experience who guide the work that I do. And the biggest take-home message that they have is all of the intervention in the world may not be helpful if there's not a certain premise. And that premise is the person I'm sitting with does not panic, that in some way they show that they are with me in this moment, and they figure out a way to offer hope. Not in a, it's gonna be okay, I have all the answers, but in a, let me help you get through the next 5 minutes, or I've seen how strong you are and I have hope for you. These are some of the insights that we have from people with lived experience. I wanted to make sure we talked about briefly before we hear from our other speakers to hear about behaviors. So I look forward to introducing our colleague, Dr. Kathleen Wilging, who's the director of the Pacific Institute for Research and Evaluation at the Southwest Center, where they're also a senior research scientist. So I turn it over to you.
Thank you. And thank you for inviting me to take part in today's panel. Before I begin, I'd like to acknowledge that I'm presenting from Albuquerque, New Mexico, the traditional homelands of the Pueblo of Sandia. This afternoon, I'll talk about known barriers to suicide prevention and general healthcare access for lesbian, gay, bisexual, transgender, and queer or LGBTQ people, and ways to overcome them using implementation science. Next slide. First, I'd like to acknowledge the National Institute of Child Health and Human Development and the National Institute of Minority Health and Health Disparities for funding much of the research that I'll talk about today, and to give a shout out to our community partners. And I have no conflicts of interest to report. Next slide. With almost 2.1 million people, New Mexico is a culturally rich majority-minority state. It's also mostly rural and economically challenged. Suicide is a leading cause of death, with the state experiencing higher rates of suicide than the US average for the last quarter of a century. Rates of suicidal behaviors for LGBTQ adults and youth far exceed those for heterosexual and cisgender New Mexicans. In 2019, over 19% of sexual minority adults and 22% of gender minority adults had reportedly thought about committing suicide, while 41% of high school students had considered attempting suicide, with little more than 34% developing a plan and close to 25% making an actual attempt in the past year. These disparities in suicidal thoughts and behaviors are linked to exposure to structurally based stressors, such as discrimination, associated with being part of a socially stigmatized group, as opposed to being LGBTQ in and of itself. Next slide. New Mexico is medically underserved, with most services concentrated in its largest city, Albuquerque. All or parts of 32 of 33 counties are primary care health professional shortage areas, with 50% of the population living in such areas. About 60% of residents live in mental health professional shortage areas. The state's behavioral health system is fragmented and fragile, a situation exacerbated by the forced closure of community mental health centers in 2013, creating mental health care deserts throughout the state. Although primary care is a major portal into mental health diagnosis and treatment in the US, our clinics must struggle with ramping up their service delivery capacity, given there's few places to which they can refer patients. Most practices have yet to try tailoring services to LGBTQ patients. Frequent contacts and longstanding relationships between providers and their patients should make primary care a key setting for suicide prevention. Yet appointments and wait lists for services are long everywhere. Schools are another de facto source of support. As the one place where young people spend most of their awake hours, it's a setting in which adults can be primed to identify and address signs of risk for suicide, thus serving as an ideal site of primary, secondary, and tertiary intervention. There are 70 school-based health centers that provide primary care and behavioral health services, including suicide prevention. But the state has 89 school districts and 877 schools, so centers are available to a fraction of the school-age population. 18 of 88 school districts have less than one full-time school nurse, meaning school nurses are stretched, with more than 1/3 serving multiple campuses. In 2009, 40% of nurses in high schools provided emergency management for a suicidal student, increasing to 75% in 2019. Next slide. Today's talk draws from two studies shaped by implementation science, the study of processes for supporting movement of evidence-informed innovations into routine practice. Our first study is a statewide randomized cluster trial initiated in summer 2016. This study uses implementation science to enable uptake of evidence-informed practices to make high school safer in New Mexico and more supportive of LGBTQ students to reduce their risks for suicidal behaviors. Our second study employs a mixed method research design to assess factors impacting access to quality primary care for LGBTQ patients, focusing on clinical preparedness, implementation climates, and readiness for LGBTQ-centered care in clinical settings. Next slide. Social institutions like health systems and schools perpetuate cultural values of heteronormativity and cisgenderism that can harm the health of LGBTQ people from youth into adulthood. The attitudes, language, and behaviors of health and school professionals can engender hostile climates, marginalizing LGBTQ people and making them feel disconnected. Experiences of discrimination in these settings, like the biased enforcement of rules that disproportionately target LGBTQ youth and students of color, combined with the social pressures of being part of a minoritized group, contribute to school pushout and a domino effect of other negative consequences that can heighten a young person's risk for suicide as they age. When LGBTQ people experience discrimination in healthcare settings, they may delay or avoid getting the care they need. Seemingly benevolent discourses of "we treat everyone the same" are often invoked by staff in both types of institutions to signify that they don't discriminate. Yet such discourses may reduce their motivation to get educated or support evidence-informed policies and practices that might benefit the health and mental health of LGBTQ people. Finally, a pervasive lack of education among health and school professionals contributes to the invisibility of LGBTQ people in institutional settings and low awareness of what's unique about their mental health needs. Next slide. Several barriers thwart access to needed support in schools. First is not having enough health professionals, including school nurses, as discussed earlier, and therapists. School counselors focus on academics, while social workers are charged with special education caseloads and rarely serve the general student body. Not having enough health professionals makes it hard to identify and to respond to any student with suicidal behaviors, let alone those who are LGBTQ. Moreover, school staff are often unsure as to whether community providers are LGBTQ competent, despite really hoping they are. Professional development for school staff on suicide prevention and intervention occurs infrequently and is seldom reinforced through follow-up training. Given high turnover rates across schools, many staff are thus likely to lack basic preparation to deal with suicide. We've also found that that training on suicide is not usually a top priority for school leadership unless it's initiated by students or the community during times of crisis. School staff cite low mental health literacy and insufficient engagement among parents and guardians as major challenges in making sure students experiencing suicidal behaviors get support. Stigma about having their kids identified with mental health concerns or as being LGBTQ creates further resistance to needed services and support. Likewise, primary care providers point to the difficulties of delivering private, confidential care to at-risk LGBTQ youth with unaccepting families, as was discussed earlier. Next slide. There are several challenges in primary care clinics that make it hard to address the needs of LGBTQ people at risk for suicide. The providers and staff we've talked to make it clear that clinics could be doing more to engage in outreach and advertise their services to LGBTQ people to pull patients in for care. They report not knowing much about LGBTQ resources outside their clinics, like where to get training or places to refer patients with mental health concerns, such as LGBTQ support groups. One reason why outreach isn't happening is because administrators are not seeing a need to engage in these types of activities. Again, LGBTQ people remain off the radar, and the demand for LGBTQ responsive services is deemed low. Not having electronic medical records set up to collect and make use of data on the gender identities and sexual orientations of patients, or staff prepared to ask appropriate questions to get this information, likely contributes to perceptions of low demand. In some places, administrators don't want to do things to create LGBTQ responsive services because they don't want to make non-LGBTQ patients resentful or uncomfortable. Having to care for patients of varying ages and cultural backgrounds also makes it hard to justify innovating services for LGBTQ people, contributing to the siloing of expertise in which only a minority of staff may possess the knowledge and skills necessary to work with LGBTQ patients, especially with respect to gender affirming care. Next slide. A big finding from both studies is that people really don't know what they don't know. Until they started taking part in our studies, many folks we've talked to hadn't given much attention to LGBTQ issues in their workplace, meaning they didn't have a reason to prioritize or invest in inclusive services or support. Because these issues are on the periphery of their radar screens, if at all, preparedness to intervene appropriately to reduce negative health and mental health outcomes for LGBTQ people is minimal. We've also found that through professional development, we can make substantial inroads in enabling persons in these institutional settings to become more involved and to initiate processes of organizational change. Next slide. There's some basic evidence-informed practices institutions can do to reduce access barriers and health disparities for LGBTQ folks. Schools can establish safe spaces and social groups on campus that promote school connectedness among LGBTQ students, a major protective factor against suicidal behaviors. They can also adopt inclusive curricula that don't neglect LGBTQ health concerns and foster mental health literacy. Schools can vet community providers, confirm they're knowledgeable about and friendly towards LGBTQ people. Through our research, we've collaborated with schools to organize LGBTQ 101 trainings for local providers, attracting attendees by offering free continuing education credits. Clinics can also do more to create welcoming environments for LGBTQ patients by increasing outreach in communities, transitioning to gender-neutral restrooms, and displaying artwork and educational materials that signify their friendliness. Collecting data on patient gender identities and sexual orientations as part of routine clinical care can make it possible for staff to understand and address disparities impacting LGBTQ patients. Clinics also have a responsibility to ensure LGBTQ patients receive care in keeping with national recommendations and best practices via targeted workforce development. Everyone working in schools and primary care must be expected to and empowered to become familiar with basic approaches to cultural competency when interacting with LGBTQ people. They also need to be proficient in using common LGBTQ terminology. Shoring up discrimination policies and their enforcement at an institutional level can guard against marginalizing LGBTQ people. Finally, by forging connections with LGBTQ communities, such as with advocacy organizations, schools and clinics will find eager collaborators willing to make these things possible. Next slide. Still, stuff gets in the way of introducing innovations to support health disparity populations at risk for suicide, like LGBTQ people. This includes social factors. For instance, being from a small, socially conservative community where stigma surrounding mental health and LGBTQ issues abounds can make staff less likely to get visibly engaged as change champions. Pragmatic considerations, namely time constraints, being overworked, and not having enough resources, also get in the way of carrying out LGBTQ inclusive practices in schools and clinics. Lastly, leadership support and alignment is essential. For example, against the wishes of school nurse leadership who were excitedly awaiting the receipt of implementation support for suicide prevention, 2 principals decided unilaterally to withdraw from our school study based on their beliefs that LGBTQ students didn't warrant special intervention. Leadership may also deprioritize LGBTQ initiatives for less problematic reasons, as their energies are often devoted to ensuring that schools and clinics comply with the many, many state and federal mandates governing education and healthcare delivery. Next slide. We must expect change in institutions to foster suicide prevention and intervention for health disparity populations. However, we can't demand change without investing in the institutions and people who work within them to do things differently. Professional development that cultivates knowledge and reflection on the social causes of ill health and reasons behind inadequate or fragmented support is key here, and it can't be done in a one-shot training. While a focus on health risk behaviors at the individual level is useful for professional development, it can also reinforce stigma and stereotypes when it's not paired with attention to structural and systemic processes that deepen inequities for minoritized social groups. Although I don't have time to fully discuss, adoption of a structural competency framework to organize professional development can be useful by enhancing awareness of upstream factors, such as stigma and discrimination, that abet marginalization and give way to disproportionate risks for suicidal behaviors, while advancing the case for larger order interventions focused on changing implementation environments, overcoming institutional inertia, and doing something about adverse health outcomes for particular social groups. Next slide. Implementation science is orienting itself to tackling health disparities. Frameworks such as the exploration, preparation, implementation, and sustainment model help us think about how to overcome barriers and promote access to suicide prevention and intervention in institutional settings. Such models focus on multiple stages and levels of influence during change processes, encouraging initial and ongoing assessment of factors at the outer context, like the broader system environment, policy, funding, community stigma, and inner context factors or characteristics internal to a school or clinic, such as staff and leader attitudes and behaviors. Such models offer roadmaps for crafting climates conducive to successful implementation. The field also features tools to enhance the uptake of new programs or practices. Implementation strategies we've used to build capacity among diverse stakeholders to wrestle with health disparities include the dynamic adaptation process and implementation facilitation. In closing, implementation science is about addressing messy, important problems, including health disparities and structural incompetence. Addressing such problems is complex and takes time, but is essential to carrying out evidence-based suicide prevention and intervention in schools, clinics, and other institutional settings, and for reducing high rates of suicidal behaviors for health disparity populations. Next slide. Thank you very much for listening to me today, and I just appreciate you being here.
Thank you, Dr. Wilgang, for your experience and sharing guidance that you brought. Next up, we'll turn it back to Dr. Lisa Brenner. I'll turn it to you, Dr. Brenner.
Thank you. One way that we are able to kind of do a better job at making suicide prevention services available is by screening upstream. And this is something that we have worked very hard in the VA, moving suicide prevention screening maybe is something that only happens in specialty care to something that happens all over this system. Next slide. Next slide. So VA has implemented something called VA Suicide Risk Identification Strategy. And this strategy, as I said, it's a national standardized process for suicide risk screening. And what we're doing is using high quality evidence-based tools and practices, some of which have been taken from the clinical practice guideline, and really use those to facilitate and encourage fidelity to best screening practices and evaluation practices across the healthcare system. This really is the largest effort that has been undertaken in any healthcare system in the United States ever. We've screened about 6 million, I was just texting in between, 6 million folks in the VA getting care. And so that means folks who maybe don't get to specialty care or may not have the propensity to go to specialty care for any reasons still would be screened for risk of suicide. The risk ID outlines clear processes for who should be screened or evaluated, when the screening should occur, and how the screening should occur. Next slide. So there are specific universal screening requirements, and that is an annual suicide risk screening that is done every year for every veteran by appropriate staff when it's due. There are specific clinical settings. This is additional requirements in specific settings where we know individuals may be at risk. And then there's also this idea that, like, because you've done the annual or the setting specific, you should still continue to use these same procedures, these best evidence-based practices when they're clinically indicated. Next slide. It's a two-step process, and the first step, and I should say that this process has evolved over time with new evidence, and we expect that it will continue to evolve over time with new evidence. The first step is a screener, and the screen is to detect anybody who may be at risk for suicide but is in need of further evaluation. And then there's a comprehensive suicide risk evaluation that's a formatted template to inform about clinical impressions about acute and chronic risk, and then associated disposition. And what we want to do is we want to match risk level with appropriate treatment and help providers and patients select treatments that match the level of risk for the individual. Next slide. As you can see here, there's a number of different settings that this is happening in, some of which are probably not surprising to folks, like inpatient mental health, or perhaps in mental health residential rehabilitation programs. But you may be not used to seeing them happening in sleep clinics or pain clinics. It's also happening when folks go in and out of the hospital. So really trying to make this a whole system of care effort to begin screening and evaluating. And that means we've got many, many more providers who now think suicide prevention is part of their business and that they're responsible for it in their screening and treatment situations. Next slide. We've also provided a number of resources to support those doing this. Some folks, are very used to suicide risk screening. Other folks have needed more assistance. So that's required additional trainings. We've got laminated screening materials available, dashboards that we use with providers to tell them how they're doing. We've got technical assistance, a technical assistance support line, a distribution list. So really trying to support the providers at different settings and at different types of care, really implement this whole of enterprise process. Next slide. Next slide. This is an example of a dashboard that we're using. And what you can see, this has 2 of our programs on it, but this kind of information actually helps providers insights, figure out how they're doing, who they're missing, why things might be missing. And so this can also help us improve overall levels of practice and the way that we're practicing in workflows, and then sharing workflows between sites on tech assistance calls to really do an overall better job of doing suicide risk screening and evaluation in many different settings. Next slide. I want to highlight that some of the initial work on this has already been published. This is an article by Dr. Bahraini. And one thing that we already know is that this is possible. We're doing it. So for healthcare systems that don't think a universal screening plan is possible, It does require a lot of commitment and technical assistance, but it's possible. We're also finding that in terms of this initial data was looking at ambulatory care and the ED, that the risk level in the ED was higher, and that's what we would expect. It also shows that the overall level of individuals who really need care is small compared to the whole, yet significant. I also want to highlight that we have begun to collect initial data regarding race and ethnicity and other factors. And certainly this allows us to do more and more work to make sure that individuals from different backgrounds are getting the screening. One thing I think that's interesting here, and I was looking at this article again last night, if you look at the percentages of white versus Black or African-American in ambulatory care versus the ED that are getting the screening, it's a little bit higher for the ED for Black or African-American individuals. And that definitely calls into question, are those folks getting their annual care? Are they coming in for more emergent care? Are there more crises? What's happening? And how can we help individuals also get into regular care? Next slide. This is a study that was done in the VA, not related to suicide risk, but I think the kinds of efforts that we're doing in the VA will let us do this kind of work. This was a study that was done looking at mortality disparities in ethnic and racial minorities in the VA. And you can see what they did here is they looked at different groups of individuals, the strength of the evidence, and then was it statistically significant, and were individuals from minority groups getting better care, had better mortality rates or worse mortality rates. And my hope is that in the future, as you see us having more evidence-based practices, more systematic screening, more data in the VA, that we'll be able to do a better job of seeing, are we meeting the needs of everybody equally? Next slide. Finally, just want to highlight for those of you who are treating veterans in community care, we do have a consultation service that we provide where you can get information regarding risk assessment, like I just talked about, lethal mean safety, like Dr. Simonetti talked about. All this is available at no cost to all providers working with veterans in the community. We want to make sure folks know that this is available. Thank you.
Thank you, Dr. Brenner. Thanks to our speakers so far for this panel for talking about barriers for screening, barriers for LGBTQ+. And next we'll be hearing from Dr. Michael Lindsay, who is the Executive Director for Mick Silver Institute for Poverty Policy and Research at New York University. Dr. Lindsay will be talking about Black youth and families and barriers for their care.
Hi, can everyone hear me well? Great. So thank you for that introduction. Next slide. So Jeff talked earlier about a study that we did a few years ago looking at non-fatal suicide behavior among US youth from the years 1991 through 2017. We used the YRBS, which at that time, these years were the latest years for which, or all the years for which data were available. And as you can see here, over that span of time, about 18% of kids were thinking about suicide, and 14% had a suicide plan. And so our question, and really building on some of the great work that Jeff and colleagues did earlier, looking at trends over time in terms of these non-fatal suicide behaviors and whether there were racial and differences related to sexual identity. So can you go to the next slide, please? And the major finding was that, again, suicide attempts rose by 73% for Black youth, while decreasing for every other racial and ethnic group, which was incredibly surprising to us that there was an increase in only one group. We also observed that there was a decrease over that span of time in terms of thinking about suicide and planning suicide for every racial and ethnic group. And so we were surprised then that when we got to the suicide attempt category, we saw this increase for Black youth only. Next slide. And also, as Jeff indicated earlier, we found a significant increase in having an injury related to a suicide attempt only for Black youth, and in particular Black males. You can see this increase by 120% over that span of time. Next slide. So those outcomes made us sort of think about whether it might be that Black youth are turning right to an attempt. And again, because we saw that over that span of time, they're thinking about suicide and planning suicide, it actually decreased. And when we got to this category of attempts and injury by attempt, we saw an increase. And so that was really puzzling to us. And so next slide. So my postdoc at the time, Megan Romanelli, is leading a study that actually has been accepted with minor provisions at a journal, applying an ideation to action framework to look at within suicide behavior, non-fatal suicide behaviors, whether there are distinctions based on race in terms of which youth are engaging in the different types of non-fatal behavior. Oftentimes, as we know, when we look at outcomes related to suicides, we're comparing youth who have engaged in suicide behavior versus non-suicidal youth. And so it's important then to look within group to determine some distinctions. Next slide. So using all indices of suicide behavior that are indicated, again, thinking about suicide, planning, attempting, having an injury related to a suicide attempt. Well, actually not for this study, only for suicide attempts. We looked at the years from YRBS from 15, 17, and 19 to compare within group differences in terms of those who are engaged in the behaviors. And so we applied basically this ideation to action framework looking at 4 different groups. So the groups were kids with thoughts only, kids with thoughts and plans, and then kids with thoughts, plans, and attempts versus kids with an attempt only. And as you can see circled here is the major finding, which was that compared to white youth, Black youth were actually had higher odds of having an attempt only and not a thought or plan accompanied with that attempt versus white youth who had suicide thoughts, plans, and attempts. And actually Black youth were the highest percentage of youth within that category of having an injury, having a suicide attempt without any thoughts or plans. Next slide. So what does this mean in terms of screening and prevention? It actually is really scary when you think about it. What happens in terms of the common warning signs that we are looking for in terms of suicidal behavior that might not be as apparent for Black youth. And, you know, there are emerging studies and studies that have been conducted over the last few years, going back to as early as around 2009, was a study by Sean Joe that showed that Black youth are actually having suicide attempts with no precursor psychiatric indicators that they may have been at risk for attempting suicide. And there's this recent study that showed that there's even suicide misclassification in that Black descendants had higher odds of manner of death classification as undetermined intent relative to white descendants. So this is really an issue in terms of what are the circumstances surrounding the behaviors of Black youth and around suicide, and are we missing any sort of key warning signs? Next slide. So I've been asked here to talk about what are some of the barriers to care. And I just want to document that what we know from large-scale epidemiological studies is that Black youth relative to white youth underuse specialty mental health care. And this is from the National Comorbidity Study, the Adolescence Supplement. And then they do not receive treatment for mood disorders. And by the way, Latinx youth also did not receive treatment for mood and anxiety disorders relative to white youth. So the prevailing set of findings suggesting that Black youth are not using formal mental health services, particularly for a precursor factor related to suicide behavior like depression. Next slide. We also know that fewer than 50% of youth who access mental health treatment actually access mental health treatment following an ER visit, and a large proportion of those youth do not adhere to treatment even when they are connected to those services post an ER visit. And so, there's really a great need to bridge that divide and to really close that gap. There's a current RFA out now from NIMH about this very issue. How do we connect those kids who are visiting ER to follow up mental health treatment? Next slide. So I want to take a closer look at the barriers to care, and I'm going to talk about two broad factors. Next slide. So the factor one is related to a host of issues. I think that happens among Black youth, and certainly some of our research has documented this. There's a stigma related to mental illness and service use. So there's this double stigma that has to be addressed when working with Black families. There's the primacy of family support. And what we've heard from in some of our qualitative studies from Black youth and families is that they prefer to take their problems, their concerns and cares to family members first, and oftentimes may hear messages from family members about not taking their problems outside of the family context, and that the family is the best source of care when experiencing a mental health challenge. There's a distrust of service providers, fearing that providers will not understand your unique experiences, will often give you messages that are discordant with your contextual experiences. In other words, fearing that providers will not understand what you're going through and how best to navigate those circumstances. And then there's a lot of misdiagnosis or misclassification of presenting symptoms that perhaps may miss the mark in terms of connecting kids to behavioral health supports. Next slide. So this was a popular meme circulating through social media that about last year, I think just before the beginning of the pandemic, and it really, really hit home. And when I saw it, I said, I'm going to incorporate that in my talks because it really sends a powerful message. So there's a Black teen who conveys to a parent, I'm depressed, and he's supposed to be washing dishes, and the parent replies, depress those dishes. And oftentimes kids, Black kids receive messages like this, in that, their presenting circumstances are not consistent with a mental health issue, that they're lazy. And so there's a lot of psychoeducation that is necessary in order for there to be, first and foremost, an acknowledgement of that mental health struggle, and then obviously the subsequent follow-up to care. And so I think that this is a perfect sort of indication or a metaphor for what happens in terms of a lot of Black kids and their experiences. And by the way, this happens at school as well in terms of what kinds of messages they might hear from educators. Next slide. We did a study that was published some years ago looking at data from Johns Hopkins, Nick Iolongo, of ninth graders. And what was really interesting about this study is that half of the sample of 465 ninth graders, Black kids in Baltimore City, had identified mental health needs, but only 20% of those kids actually received services. And oftentimes those services were actually co-located in schools. And so they were proximal to their presenting circumstances, but they were not accessing those services. So one of the messages that I always have indicated with respect to the study is that just because those services are in the building does not mean that those kids are going to access it, and that there's other kinds of interventions and strategies that we need to employ when working with Black families to overcome those stigmas or those perceptual barriers to treatment. But we did find that those kids who did access services reported that they had positive or supportive networks in terms of the kinds of support that family members were giving them, particularly when they had an internalizing need. Next slide. Another factor is that in schools, as I indicated earlier, there's a lot of misinterpretation of presenting issues. For example, we know that youth with depression are likely to exhibit irritability, anger, kinds of behaviors as a manifestation of their depression. Well, if a Black kid versus a white kid is exhibiting those behaviors, obviously, in terms of implicit biases, that Black kid is going to likely be suspended or expelled from school. And so we've seen that Black kids then are overrepresented in terms of disproportionate discipline, boys versus girls, and then kids with disabilities versus those without are often overrepresented in terms of disproportionate discipline. Next slide. So there's a slide under here, but there's this really interesting study, or a couple of studies from Lisa Janetian, who used to be at NYU, now at Duke, did a study looking at poverty impacted students, and when sort of at the time of the month, those kids display the sort of highest level of behavioral concerns or problems that came to the attention of school personnel. And she found that those problems were experiencing an uptick at the end of the month and was associated with the family running out of SNAP benefits. Can you hit the slide, go to the next slide? Because, yeah, there it is, right. So income instability predicted student expulsions and suspensions, and there were spikes in disciplinary infractions at the end of the month, exacerbated in SNAP recipient families. And so oftentimes it seems to be the case that schools don't really do that next level of inquiry about what kind of presenting issues or concerns that kid is bringing to the school, whether it's associated with a lack of resources, in this instance, perhaps hunger. And then oftentimes it is the case that Black kids are disproportionately represented as part of that group who are being disciplined. And so then these kinds of issues need to be peeled in terms of the layers and the contextual circumstances that kids bring to schools that we often miss. And this is why I believe that kids are disconnected from needed services because we're just not looking for the traditional sort of mental health presentations. Next slide. I think also another issue, and I've been thinking about a few things from a policy perspective, is that less than 10 states across the country require social emotional learning standards from pre-K through 12th grade. And I think that it would be incredibly important for kids to understand how to process their emotions, how to reconcile interpersonal challenges that they have with others in a way that allows them to be able to sort of understand their emotional processing, and then perhaps be at a place to ask for help as they need them. But it just strikes me that another barrier to our challenges to connect folks to care is the fact that we don't have these kinds of standards from pre-K through 12th grade. Next slide. But the biggest policy related barrier to care is that every school should have a mental health provider, and it should be proportionate to the number of kids in schools. And oftentimes we find it is the case, particularly in communities of color, that there's not a provider available in that school, or if there is a provider, that provider is there only one day a week, maybe twice a week. And so, it means then that kids might face that day where they need that kind of support from a professional, but there's not a professional available in the school. And so that's why, next slide, please. we have been advocating for more resources, more federal attention to be given to this issue. And I was really privileged to be a part of a group of experts where we wrote this report, Ring the Alarm, the Crisis of Black Youth Suicide. And in that report, we called for more attention to be paid to how do we get professionals, behavioral health professionals in schools, proportionate to the number of kids in schools. How do we make sure that we're training the next generation of providers to be able to ensure that we are feeding that pipeline with providers that are going to be willing to go into low income, low resource communities to do this kind of work. Next slide. And so as part of that report, just really pleased to acknowledge here that the Congressional Black Caucus, namely in the leadership of Congresswoman Bonnie Watson Coleman, sponsored the Pursuing Equity in Mental Health Act, which actually passed in the U.S. House of Representatives in May by a margin of 349 to 74. And again, this was sponsored by Bonnie Watson Coleman, but also co-sponsored by Republican John Katko from New York. And a Senate version of this bill is being sponsored by Senator Bob Menendez, again, with a cue into bipartisan support to create this opportunity to provide more support for youth of color in the United States around their these rising and alarming rates of suicide and engagement in non-fatal suicide behavior. So I'll end with that and want to acknowledge, next slide, please, those who have worked with us to really do this important work that we're trying to do at the individual and as also at the federal level. Thank you.
Thank you so much for that. And thanks to all of our session 2A and session 2B presenters. Can we get everybody on screen now from those two sessions for the panel discussion and the Q&A? Wonderful. So let's start with a question all our panelists might want to address. I saw a question earlier about stressors people have been experiencing recently, and Dr. Simonetti and Ms. Endefhorn both mentioned this briefly in their presentations. I'll ask Dr. Wilging to speak first on this. Would you comment on suicide prevention in the context of the COVID-19 pandemic?
I can say there is definitely a heightened need for suicide prevention and intervention. We did a survey of 379 self-identified LGBTQ youth in New Mexico. Approximately 41% didn't feel safe in their own homes because of their sexual orientations, gender, or gender expression. Over 83% felt sad or hopeless in the past 3 months, and this was last summer. Almost 46% considered suicide during, those early months of the pandemic. Close to 33% made a plan for suicide, and close to 12% had attempted. And I can tell you one of the most difficult things is that schools lost track of those kids who might be at risk. They didn't have those adults kind of being that de facto surveillance system for them. They didn't have that safeguarding system in place. The broadband access issue in our state really aggravated some of the mental health needs for these kids because inconsistent access throughout the state. And just to even find a private space where you could engage online with a mental health specialist was quite challenging for many youth. And we had several reports of youth telling us their parents were actively discouraging them from getting mental health support. So clearly there's a lot of room for prevention, but at the same time as kids were starting to go back to school, there was all the chaos around around how do we make this adjustment. And while most of these kids were in an online kind of format, you know, the teachers themselves had to adjust. So just doing, so professional development really focused on how do we do things online? How do we educate online? And suicide prevention was deprioritized, as were initiatives to support LGBTQ youth.
Thank you for that. Before I invite everyone to comment on the COVID-19 pandemic, let's add another recent stressor to this conversation. Recent racial tensions and civil unrest might be relevant to our discussion. I'll ask Ms. Endifhorn, would you comment on suicide prevention in the context of those recent concerns?
Yes, thank you. One thing I really want to pay attention to is the fact that a lot of tribes in the Black Lives Matter movement have really come to the forefront of how are we talking about rural communities, how are we talking about tribal nations, how are we talking about the experience of living in a rural area. And many times the one that came to the biggest forefront in the recent history is the term frontier. And the term frontier is used quite a lot, from the census to HRSA to SAMHSA. We all utilize the term frontier. And it came to the forefront when Abigail Eichelhoff really talked about it from the perspective of epidemiology and looking at it from a very specific contextualization that has been brought to the forefront for tribes, for Native people, of the issue of white supremacy and the issue of colonization and colonialism, and how that has impacted tribal nations, and the reality that tribal nations are facing with not only racial disparity, but high morbidity and mortality rates and all of these high rates of disease burden. And so when we look at that from that perspective, it was a wake-up call for many of the other Native scholars, Native workers that I know and have a lot of contact with, that this is something that we really haven't talked about. This isn't something that we really haven't really brought to the forefront of how do we use language, even when we're speaking about suicide prevention. How do we use that language when we're really contextualizing and conceptualizing suicide prevention in those spaces? Because how we speak to suicide prevention in that space really matters. Because if we're calling them and we're identifying that space utilizing colonial language, then that can be a disconnect as well. And so I think we really need to think about how are we speaking, what are we saying, and really start to look at how can we deconstruct this to really meet the needs of those populations and understand those populations' unique needs and challenges.
Thank you. And Dr. Simonetti, you mentioned these stressors briefly in your presentation. Would you like to elaborate?
Yeah, certainly. So, I think about suicide prevention a lot, but my specific lens is really about firearm injury prevention more broadly than just suicide as well. And, with that in mind, I wholly agree with your reframing of the past 14, 16 months of our life. While the pandemic has maybe been a central focus for many of us, there are obviously other things that have happened in society during that time, which have placed different stressors on different households, and people have interpreted them differently, to say the very least. The most recent thing that I hear coming up in the firearm conversations with patients in the community is the news is continuing to report what is supposed to be a spike of firearm violence in many major cities in the country. And that has led to a wholesale sense of unsafety and to firearm purchasing behaviors. We know that during the pandemic, a lot of people were in the house all together under really high stress conditions. So that puts a lot of people in closer proximity to firearms, including, kids and adolescents. And we have a lot of new gun buyers in the country, at least if we're to believe the preliminary reports of sales data over the past year. So I think, my point in my presentation was this is a whole new confluence of risk factors, I think, that we don't quite fully understand. And whether or not this is going to be maybe a short-lived change in epidemiology, or whether we've actually, sort of changed the face of firearm ownership for a large proportion of the country, I don't think we know the answer to that yet.
Thank you for that. Dr. Brenner, would you like to add anything?
I just want to say that I really appreciated Dr. Lindsay's slide on the food insecurity and other factors that we may not always think of as suicide risk factors. And we have found that certain food insecurity, other challenges associated with finance are risk factors for veterans, are risk factors for folks in general. And, you know, that we really need to think about this confluence of stress. And, you know, for some individuals, for many individuals, there's been huge economic stressors around COVID, loss of jobs, challenges going back to work. And, you know, I think we were seeing on TV folks who maybe never ever used food services or food that was being given out suddenly in long lines to get food. And so, you know, how this is going to play out over time and our being smarter about thinking about kind of risk associated with economics is really, really important. And I hope we see more of that.
Thank you. Dr. Lindsay, anything to comment on?
No, I think that, you know, I agree with what Lisa just said. Thank you for pointing that out. You know, when Jeff led the way, Jeff is my hero. When Jeff led the way a few years ago and really documented what was happening with the rising rates in terms of Black youth, for me, one of the things that after being shocked to find those rates increasing in the way that, that Jeff and colleagues laid out, but I was also thinking that this is beyond a sort of behavioral health issue. And there are some larger contextual factors that we have to pay attention to: food insecurity, you know, the racial reckoning and what that has, you know, sort of meant to communities of color who are over surveilled by law enforcement and all those kinds of issues, or matters related to outcomes associated with the pandemic. You know, there are a larger set of issues that I think requires us to be laser focused in terms of looking at a wide range of factors that could be playing a role beyond psychiatric, traditional psychiatric symptoms that we might think or have found to be associated with engagement in suicide behaviors.
Thank you. Dr. Whiteside, did you want to add anything?
I just add that discomfort being such a necessary part of change, and on the micro level that us within health systems and within clinicians having to learn to do new things in different ways to meet the people that we serve where they're at was good for us, right? That feeling uncomfortable, learning something new. Ideally, that would help us maintain and improve our compassion for those that we serve.
Then we have a question in the Q&A. How do you begin to change the stigma, especially in the African-American community, to address mental health as a potential illness rather than from a negative perspective? Dr. Lindsay, would you like to take that one?
Yeah, sure. So I was just a part of this morning, a really wonderful celebration here in New York City at the Hope Center, which is connected to First Corinthian Baptist Church. It's a freestanding mental health clinic that is free to the public, and it's associated with the church. The providers are available whenever you know, folks need them, and I think they're well trained. There are folks at Columbia who are on faculty but work also at the center. It's called the Hope Center in New York City. I think that that's a wonderful example of how you can combat stigma, because what's happening then is that it's a free flowing conversation that is happening as families need those services, but also through messages and other kinds of activities that are centered at the church. So faith communities, I think, can play a really critical role to combat stigma. And I also think that we have to revisit what's happening in schools in terms of the sort of zero tolerance policies, and really turn a lens toward providing the kinds of behavioral health supports that kids need. And some of that includes working with families to provide psychoeducation, to help combat those stigmas related to, again, it's a double stigma. It's about mental illness and it's about service use that you're contending with. And I think you have to be very targeted and specific as to those various types of stigmas. But I think, though, that, again, faith communities, other non-traditional settings become a really key factor. And then one more thing I was going to say is that I work with a colleague here in New York, Gary Belkin, who used to be the commissioner of mental health for the city, who talks a lot about task sharing. And so how can we provide those kinds of supports, again, in non-traditional settings where we can destigmatize what it means to go to a professional and have, lay folks be able to be trained on how to help folks reconcile their issues and be connected to formal services as needed, I think become really key.
Thank you. Dr. Brenner, I saw you were nodding. Would you like to take our last minute to?
Oh, well, I hate to take our last minute, but I guess I disagree also with what Ursula was saying before too. And some of this is about us as healthcare providers getting comfortable, getting out of our offices, getting to where people are, meeting people in their homes or in their churches or wherever it is, on the gun range. If we're going to shoot together and learn about firearm safety, how do we get where we need to get to help people know that, we can all be in this together? And then how do we also help? And Joe, I'll just pass it to you real quick. How do we get partners, like maybe unlikely partners, to engage with us, like folks that own gun ranges?
I mean, that's happening, and that's been happening for a while now. And I think that, engaging those stakeholders provides a lot of great opportunity for outreach and to build credibility in communities where we might not necessarily carry with us the most credibility or perceived credibility. I think part of that, and we do a lot of that, is finding where there's overlap and negotiating where you don't have overlap. And when it comes to firearm suicide prevention, it turns out there is a lot of consensus that a firearm is a risk factor for suicide, and that we can work together on some things. And maybe we have to be a bit delicate about the things that we don't agree on. But I think there's tremendous benefit to finding ways in which stakeholders can collaborate in terms of getting out to the community that we might not be wholly embedded in.
On that slightly optimistic note, I will hand this over. I will hand this over to Dr. Michael Hogan for closing thoughts.
Okay, thank you. Challenge there by trying to unmute. This has been a remarkable experience, and it's really hard to try to wrap it because of the complexity, intensity, diversity of issues discussed and considered. But there are some themes here that I guess I would like to I'd like to note, that these loosely follow in a way the conversation. Suicide remains a major issue, and despite some trends that are maybe positive, even though the data aren't all in yet, but it remains a major issue and a major cause of unnecessary loss of life, and it's a growing issue among young people, especially young people with diverse backgrounds. A second thought is we've seen some progress, and I think we have to acknowledge that progress. What the Veterans Administration is doing within its healthcare system is world class, and sets an example for what we need to do in other healthcare contexts. The media still doesn't recognize that, but it's true. The expectations of accreditors are changing, certainly the Joint Commission and CARF. Not yet the accreditors in primary care, where this remains an orphan issue, but some progress there. I'm really glad that Richard McKeon put the data up about the Garrett Lee Smith program, because this is it's an issue of mine, and it ought to be an issue of all of ours. That program, which has evolved over the years, but remains a discretionary grant program, has demonstrated its effectiveness, and particularly in times when we're so concerned about some of these youth issues, it's just high time to transition the Garrett Lee Smith program, certainly when it comes to states, from something you have to compete at and you can't sustain, to ongoing federal grant support for this effort across the country. I do think it's important to note that when it comes to the care of people who are actively suicidal, we've learned an awful lot. That connections and collaboration are really critical, that isolation is poisonous, that directly dealing with thoughts and impulses for suicide is necessary and is effective, and that means control and reduction are really crucial. So we've learned those things, and it's high time to bring those things, as we have in the VA, across the rest of our healthcare system. Context, when it comes to suicide and suicidal behavior, is really, really crucial, as a number of people have said. And context these days, in these somewhat United States, is very challenging. There are some things we can be hopeful about, and I'll just emphasize the hopeful side of some of these things. We are, or are we, maybe it's a question, slowly beginning to evolve the attitudes about race, and to come to a reckoning about race. It's always two steps forward and one step back, and sometimes it's two steps back and one step forward, but it seems we are making progress, and that's tied up with all these issues. Similarly, we see slow but remarkable progress with respect to attitudes about gender. And we know that both culture and gender are pivotal when it comes to suicidality. So those are big issues for us as a society, but they're issues about suicide prevention as well. The last, I guess my last thought is that our upstream suicide prevention efforts are important, but they are so colossally underrepresented or under-resourced that we can't pretend that we can achieve what needs to be done until we make a change. The national movement to turn on 988 as a single phone number for people in distress or people who are suicidal next year can possibly be a turning point, but it's only a beginning step. We have to do much more, especially upstream. And I'd like to just close by thanking the staff of the National Academies for all the work in bringing this to us, and for riding herd over the planning. Hope that participation has been useful for all of you, and we look forward to seeing you again in the second session. Thanks everybody so much.